All right, why don't we get started? I'm Steve Bolling. I'm in Michigan. My co-moderator is Firas, somebody or other from somewhere or something. And and we have a distinguished panel up here. We're going to start, and this is all going to be case-based. There's going to be good discussion. And so Mark Ricciardi is going to give us a case, my ultimate mitral case for 2025.
Dr. Bolling, may I interrupt the chair for a moment?
Sure.
Could I ask Dr. Markus Scherer to come up here? We need another imager. Nadira's feeling lonely. Thank you.
Markus, you got pulled in.
Mark, Paul set me up for tricuspid. I'm glad he set you up for mitral. Here, take this. Steve Bolling doesn't need a microphone.
This is true. All right, excellent. You know, when you used to pick on me, that was okay, but now when you do it, it's elder abuse. You know that. I don't agree. All right, good. So, how you doing? So, I'm going to try to advance these slides somehow. Did you give me one without? There we go. All right, good. So I put my faculty disclosures on the site. Is this a little funky? It looks very empty. Working?
Works better.
On the Good. So here's the case. 74-year-old with severe symptomatic bioprosthetic MR with flail. The valve, I'll show you that in a second. In 04, had a repair, P2 quadrangular resection, then a 31 Duran ring, had a maze and an appendage ligation at the time, and a few years later came back with a recurrent MR and had a right thoracotomy mitral valve replacement now with a number 27 BioCore. As you probably know, that is a true ID of 23, and we thought it sized for 26S3 valve. Here's the TEE. You can see disruption of the leaflets of the bioprosthesis, a lot of MR on both 2D and 3D images.
Hey, Mark, can I say something? This is supposed to be a little bit interactive.
Yeah.
For the cardiologists in the room, and most of our cardiologists, there's a difference between how that valve presents when it fails and a bovine valve. That's a porcine valve. All of them calcify, but you guys need to know, we need to know that when a patient with a bovine valve presents, it's slow stenosis. Whereas a porcine valve calcifies and occasionally can rip themselves. They'll rip a leaflet, because remember, that's an actual pig leaflet in there. The bovine ones are bovine pericardium. So the presentation for the valves are different, and you have to know, we have to know what type of valve that is in there, because their presentation in the porcine one can be very catastrophic. Was this guy in bad shape? Was he in trouble when he came in?
No, he wasn't. And this was a little bit of an older valve, but it did happen suddenly, and it had been followed very closely. And
right.
So yeah, great point, as always. So there's the gated CT. These are all just still frames. You can see the Duran ring was left in place. I don't know if that's conventional or not.
No.
Okay, there it is. Generous Neo-LVOT. You can see that on the upper right panel there, the fossa mitral relationship looks pretty reasonable. In the bottom right, tremendous amount of bowing of that left atrium into the right heart. Our plan was for a transfemoral timber with a number 26 valve with a balloon valve fracture with a 26 true balloon. Nothing major, right? Seems conventional, everyday stuff. Good. So the challenge was the transeptal, and that's what this is about. What I'm showing on the left there was the transeptal. After switching, we had talked a lot this morning about right transfemoral versus left. So the right transfemoral access, I could not even do puncture. And I tried everything. I usually use a BRK needle. Don't shoot me for that. But I quickly tried other, versicross and all that stuff. And what we're seeing here is after I switched to left transfemoral, and that's the back end on the left frame there. That's the back end of an Ostato wire that I energized just across. But it became very apparent, even though the height there maybe isn't terrible. What does that say, 2.7 on the right? I just couldn't maintain access. Anytime I put anything up the transeptal sheath, everything backed out. So I actually aborted this case. never implanted the valve. I thought about the different possibilities for what was going on. We did not see a prominent eustachian valve. These IVC anomalies that we read about, we don't often see much, and this person didn't seem to have that. The fossa location, like I said before, was okay. It didn't seem particularly thick or anything like that. And crossing it wasn't a big deal. It was just maintaining the catheter there. RA enlargement leading to distortion and issues with maneuverability of your device, different possibility. And then what about just this idea of IVC RA offset, difficulty steering the transeptal sheath? And that's what this is about.
Hey, Mark, can I make one more comment? Did somebody go back and look at the op notes? Because that, to me, looked like a postoperative septum. So, you know, as a surgeon, we can approach directly through the left atrium, and sometimes, especially since this patient has had 2 operations, we will cross transeptally. We'll open the right atrium, open the septum, and then do the mitral again. So that looked relatively thick. That can change the anatomy of that and make it thicker and harder to cross.
Yep, that's a great point. So this was done through a right thoracotomy to make it more likely they went through the septum there?
Right, probably. Not necessarily, but probably. It's just something that we have to have in the back of our heads when we're approaching somebody who's had a previous valve. We're going to go do a valve and valve. You know, what's the angle? Does it change the angle because we've closed the septum and we've wadded it up? And the most common thing we'll see in echo is there's not much of a fossa. There's not much of a thin area and so on like that.
Yeah.
Can I ask a question too? Just looking at the CT image, you know, everyone does the transeptal drag high to low. If you look at that one, and that septum is so bent, it's like pushing things into. This one almost looks like if you'd be willing to go, because look at the straight shot from the inferior aspect of the septum. Did you try that going low to high and just going straight in?
I did.
Okay, just checking.
Did. But it's a great point. It's an absolutely great point. So what we did is we went back and looked, after we had aborted the case, we went back and looked at these pictures, and I think the right picture, our advanced imaging fellow did this for me, shows the IVC relation to that RA, and almost a 90-degree bend into it. So then we did a little more analysis of that CT, and you can see the issues here. So on upper left, you can see I labeled it AP, the relationship there. So in green is the SVC, in orange is the IVC, the fossa is in yellow, and then the mitral valve is in red. And you can see on your conventional AP or LAO views that you do your transeptals in, there's a real hook, and that relationship between the IVC and the RA was not favorable to get to the mitral valve. And you can see the RAO view, which is essentially the implant view there, making things very difficult. Okay, so what do you guys think? What would you just try again, get a better operator?
Yes. Try again, but from the neck.
Yeah, okay, good. All right, so neck?
I mean, so we're classically taught that severe LA enlargement causes flattening of the fossa. Severe right-sided disease causes verticalization. This is one of the most extreme left atrial, left-sided flattenings that I've ever seen.
Actually squishing the IVC.
Yeah, so in these situations, we're taught to make the needle as shallow as possible, almost straight.
Yes.
And that's what Markus was commenting on, just using a straight needle and coming down, because the curved needle, you'll never be able to, well, I shouldn't say never, but it's just really hard to get any push because you're coming at it at an angle.
Exactly.
So.
Yeah. So for those big RAs, we tend to put that huge hook on the needle, and this would be the exact opposite.
Yep.
Yeah.
So the Brock needle would be, honestly, your best friend, because it's probably the straightest, and it'll maintain that straightness because it's the stiffest of them all. So
yeah.
Ross, how would you do?
Yeah, with that being said, though, I mean, the procedure is not transeptal. The procedure is you have to get the valve across. So you might be able to cross this transeptal, but then getting balloon and getting the the valve to cross might be another adventure. So I would look for another way to cross the septum in this case.
So my team was a little surprised that I was taking off my lead. They're like, "You just got the transeptal. You finally got it."
Yeah.
But I was very concerned about backing out, and so this is my partner's appendage case. This is a transhepatic access. Would anybody try this?
I'll let you try it.
So you did not want to do the from the neck approach?
He's a big fella. No,
Okay.
I didn't. But that was, so one transhepatic, but I thought the IVC-RA interaction was the same, so I didn't want to go from below. And then this is the idea of doing a transjugular. I have not done a transjugular timber. But that doesn't mean, and this is an example of obviously a mitral clip done from the transjugular. Have you guys done that?
No, I mean, but you could certainly, one, he could be a third-time redo surgical candidate.
Sure.
And if there's absolutely no way to get in there, just do it transapically. Transapical in a third-time redo is actually pretty safe because the apex is stuck up there.
just-
And this
here.
guy's not going to have a
Let me just
blown
give
up.
you-
You want me to give this talk? Okay, good.
So it's good. You don't think that's a crazy idea? Yeah, that's what I decided to do. Yeah.
good.
Yeah, I thought these were options. I didn't like the transhepatic option, but we definitely thought about that. So we went.
Is that the third time redo?
Yeah. So, and there it is. That's certitude sheath on the left frame, but on the very right of that, you can see that 21 French sheath. Crossed obviously very easily and deployed this valve very easily. What do you think about that valve positioning? A little too atrial? Super atrial, right?
Well, actually, I can't remember the ring relationship.
Duran.
Yeah, I mean yeah.
Right.
You want to be on the LV side of that ring
Totally.
with your deployment marker.
Totally. So this is an epic
Yeah,
core.
yeah.
You can't see it
Can't see it, so
from this
I think-
podium.
I
You
think
can
the
barely
point-
see it in the room.
Yeah, I think the point is the ring is sitting up higher.
Exactly.
But you probably figured, you were very smart here. You figured out
I
where you
wouldn't show
needed
my
to be.
stupid cases.
You
That's
knew
for
it.
home use only.
That's right. You
So
and
Mark,
me
I have to
both-
say,
you and
this
me
is
both.
the only case of valve and ring that I've ever seen in my life.
Too. Me too.
I have never I've only done about 7,000 mitrals, so I have never put a replacement inside a ring.
Yeah,
Which
I-
seems weird to me, but
Yeah.
okay.
Yeah. So
I mean,
but
how much
Did
difficulty
you,
is
did
it?
you BVF before?
did I BVF before? No, I
No.
did it after. But I just, this is not the point of the talk, but I mean, maybe if you squint, you can see the epic, but it's not in line. And even the Duran ring here is not lined up perfectly, but that epic valve is. So this looks very atrial.
I think the position is probably okay, Mark.
Yeah, well, and I'll show you. It's perfect.
Even if you say so yourself.
But that's just an aside. It went in fine. So learning points here. Transeptal is still very important for so many of the procedures we do, valvular and appendages, several anatomic issues, but this IVC-RA offset, which we're talking about more and more, certainly presents some challenges. Although I think we overcome them almost always. We're probably seeing this a lot, but we overcome them. Know when to abort, regroup, review your images is important, I guess. Nobody likes to stop in the middle of a procedure and give up. But I think in this case, it was the right thing to do. And then consider all your alternative options, including the barbaric transapical approach.
Thanks, Mark. Thanks a lot. I think transapical is always an option. I mean, surgeons know how to do it. It's not that bad, especially in a third-time redo, that you won't get into difficulty in the apex kind of thing. So I think it's a good option when you get stuck.
And you think the mitral LV versus the aortic stenosis LV makes a difference?
It does. I mean, the ventricular apex in an aortic stenosis is 1.5 inches thick. You're never going to lose control of it. It's the FMR cases that are 2 millimeters thick that you lose control of the apex. But this guy's all stuck up there. He's going to be fine. That's a good technique, and it's really easy to place it because you're on a super short
So
stick.
easy, yeah.
I think for what'd you say your name was? I think he was right that you would have, even if you got across, you'd have trouble getting everything else across at the wrong angulation.
So what happened with the fracture, though? I thought your original plan was to fracture.
I
them.
didn't show it because
But the reason why I say that
Yeah.
is I am not sure that they still make the transapical sheath. I think right now, if you decide to go transapical, you have to go with the long,
long.
transfemoral sheath, and that can make getting balloons in and out for fracture is a little bit more more challenging. So I mean, you should take the credit you deserve for this case because now this is a tough one.
Yeah. I've already officially taken credit for this.
You know,
He's
the reason why I'm on the panel today is because Paul wanted a big guy to protect the speaker from,
noticed the positioning here.
from Steve. So.
All right, Mark, thanks a lot. We're going to move on now. We're going to have, Tarek's going to give us a talk about Batman, a technique for minimizing LVOT obstruction in TMVR.
Hello, everyone. Thank you for the panel, for the kind invitation. I walked into the room and I'm looking for a podium. I usually like the shield, standing behind something, and now I'm sort of totally exposed. So it's a pleasure to be here, and I understand that I have a little bit extra time because there's opportunity. So I'm gonna I added some slides, so we're gonna talk about mechanisms and techniques to minimize LVOT obstruction during TMVR. So let's see, how did you make this work? There we go. I only leave this slide in there because I always want to remind myself where this whole thing started. This was in St. Louis University with Michael Lim and Rick Lee sitting in an office discussing the TMVR cases. And one of the patients had a severely long anterior mitral leaflet, and we're concerned about LVOT obstruction. And this is something that has come up over and over again. So TMVR, you realize that the risk of LVOT obstructions is upwards of 20% or so. And when this happens in the procedure, it can have significant, drastic consequences. So I'm not going to belabor the point. All of you guys know that we evaluate this with CT, with TEE, and we have distinguished imagers here that help us through this. But I'll show you some of the cases, and I'm glad that we talked a little bit about the barbaric transapical approach, because this is going to be a focus of this talk. So this is an example of one of the patients that we faced. Significant septal hypertrophy, a very long anterior leaflet. The angle, the aortomitral angle, is not very favorable, and this is an example of how the anterior leaflet will touch the septum if pushed in with a valve prosthesis or a valve implant. So when we thought about this, the lampoon was already out, and we talked about that as an option, but I think we wanted to do something that is different, and we wanted to try a different approach. The surgeon, actually, and if you know this, that we could do septal ablations and leaflet modification. The lampoon was the cautery-based laceration technique, but then we thought we'd do something that is a little bit different. The surgery presence was important for this case, because when we talked about this, the surgeon said, we deal with these patients in a different way in the OR. So apparently there is an anterior translocation of the anterior mitral leaflet during surgery for chordal preservation during the mitral valve replacement. And he said, why can't we replicate that through a catheter-based approach? So we decided that this is a maneuver that is worth trying, with the surgeon's support, of course. And we thought that we go transapical and puncture the anterior leaflet, deliver a wire, and balloon the leaflet to translocate it posteriorly and implant the valve in the hole or the defect that is created by the balloon. So, surgical moderator, what are your thoughts?
I think it's fantastic. I mean, we obviously always flip the anterior leaflet backwards when we're going to do a replacement and something like that.
He told us that they actually slice through it and they deploy it.
Yeah, we curve on a long arc,
right,
and pull it backwards, tack it to the back, and then put in that space. So it's very analogous to that.
Yeah. So we decided that this is going to be the way to go. So we did the transapical approach, and the surgeon had a probe on the heart, and he actually, with the pericardiocentesis needle, navigated the needle to puncture the anterior leaflet in the specific location that is mid-level and from base to tip. And this is the location of the puncture. This is going on autopilot. So as you can see, this is in the 3D reconstruction, midway between the base and the apex, and halfway in the leaflet. This allows you a little bit of protection, so when you inflate the balloon, you don't injure the annulus, and allows you a little bit of capture and purchase on the leaflet to displace enough tissue. And then over that wire, we got a valvuloplasty balloon, and you can see that the balloon was inflated within the leaflet. You see the bottom here, Oh, this went too far. Boom, one back. One back. All right, play. Their audio, there's no audio, people. Okay. It's not playing anymore. There it is. One more. And here you see that on the bottom here, the balloon will actually fracture the leaflet, and the valve is deployed within the defect and the anterior leaflet. So that was through the transapical approach. The patient was supported, of course, hemodynamically, and the surgeons got in, got out, and patients did well. We did 3 cases. All of them did well, except one actually expired after the procedure because of post-operative complications, sepsis and renal failure and the else. So this is an actual very nice image of the stent or the sapien valve being deployed within the hole in the anterior leaflet. And I'm trying to keep up with the images here. Inflates, inflates, inflates. And then, actually you can see it there. The advantage that we believe is offered by this technique is, number one, it preserves the chordae. Number two, it displaces the anterior leaflet, translocates it posteriorly. And number three, the leaflet tissue acts as a skirt to minimize PVL around this. And this is the end result. And as you can see here, very excellently deployed valve with good function. So that was the first thing, and we published this back in 2019, I think, and we called it the Batman. And I want to just spend a little bit of time talking about why we came up with this name. I think the focus here is going to be the translocation part, because this is the concept that we shot for when we actually came up with this idea, because the surgeons, our colleagues, the surgeons, actually did this with us. The balloon part is so totally different from the cautery-based laceration part. So there are a lot of names that came up with this procedure, but I think this represents the actual concept and mechanism behind which we can actually do this. So we'll zip through this. And at that time, we thought, you know, we can't do transapical all the time. People are moving transeptal. And these were some of the sketches that we thought that we actually would present within the paper to actually move it forward. So fast forward about 4 or 5 years later, and then transeptal Batman comes along. Antonio Colombo's group did one. Maisano did one. And Maisano actually has a very interesting take on this. And then Paul calls me up one day, and he says, we want to do the first in man transeptal Batman for valve in MAC. And I said, okay, I'll look into this. And we went there, and we did that case. Nadira was there, Paul was there. And this is an elderly patient with severe mitral regurgitation with a very long anterior mitral leaflet, is about 27 millimeters. And the Neo-LVOT was less than 200. So the decision was to go forward with a Batman procedure. The transeptal puncture was about 4 centimeters up. The puncture of the anterior leaflet was done with an Astaro cauterized wire. As you can see here, the position of the puncture was excellent. And we advanced that, and over that, we put the wire. And this is the balloon inflation within the anterior leaflet to create the defect. And this is one of the coolest pictures that I have for this presentation. And as you can see here, it keeps going and going and going, and then it gives way. And now you have a wonderful defect in the anterior leaflet with the wire anchoring it in the left ventricle. And over that, we actually got the valve to be deployed. And the procedure went very, very well, actually. This is the result. Excellent functioning valve, no paravalvular leak, no gradient, and no LVOT gradient was noticed in that case. The one technique that is a little bit of a variation of this, Maisano does the double wire, where you actually have 2 wires in the LV across the transeptal. You balloon over 1 wire, and you have your valve ready. As soon as you deflate your balloon here, the valve goes in right away. It minimizes the time where you have the MR and allows you a little bit more stability. The Greek people actually ballooned the valve balloon the leaflet, balloon the septum, and put the balloon back into the leaflet to minimize the MR, and use it as a buddy wire or a buddy device to deliver the valve to make sure that it delivers in the right position. But despite sometimes having a deeply implanted valve, you know that the leaflet is displayed, translocated, and the flow can continue through the cells of the sapien valve. So I think this has sort of gained a lot of momentum recently. There's been a registry that's been generated. Puvi Sashaya out of Cincinnati thought of a more minimally streamlined approach where you actually puncture the septum with a VersaCross, and through a guiding catheter, you puncture the anterior mouth leaflet with the same VersaCross wire using RF, and you position the wire there, exchange it to a stiff wire, and skip the couple of steps where you actually have to change the puncture of the anterior leaflet to the stiff wire in the LV, and then you deploy your valve, and the case is done. So there's been a lot of variations as well. Some people are using shockwave balloons to manage calcified leaflets. Some people are doing retrograde access. So it's something that we are very fortunate to have been involved in. And the concept of the balloon-mediated translocation of the anterior leaflet is proven to be very, very useful. And as we streamline the process even further, it becomes a simpler and easier thing to do, less time and less chances for wire displacement. The only question I have for the panel is, with the advent of newer devices for transcatheter mitral replacements, do we think that this is going to be an issue? The LVOT obstruction continues to be an issue, and is these maneuvers going to be still needed, or are we going to go away from this with better devices and better techniques? I don't have the answer to that. That's why I'm asking you guys.
Thanks, Rick.
You're skipping on the answer.
I know. I'll give you my take on that. I don't have the answer either, obviously. I mean, the Batman is a great thing, and it does sort of simulate translocating the anterior leaflet and gets out of the way. And the problem with the obstruction is that the cells are covered by the anterior leaflet. Now you're blockading the LVOT. However, there has been reported LVOT after this procedure too, as well. So right. it's not foolproof. It's also somewhat complex. Do you think, Paul? Do you think everyone can do this procedure?
I mean, I was actually shocked. So, first of all, Tarek, congratulations on pioneering this technique. I mean, this is that patient that we did. I saw her actually last month, and she gave me the biggest hug. And Nadira and I actually brought her roller skates afterwards, and she's roller skating now, thanks to you. So thank you.
Can she play the piano too?
Huh?
Can she play the piano too?
but she's got full makeup on and just doing amazing. And so, no, I think, Steve, your point is very valid. I mean, to be honest, I was shocked how straightforward it went, and we've done others since. If you have a good imaging view, Nadira, we can talk about that more, but the traversal of the anterior leaflet is actually pretty easy. And I'll have a video and a talk later, and I'll show you one too, but it's not hard. And then it just becomes like a valve and Mac.
And you do it under rapid pacing or adenosine to stabilize the leaflet.
Yeah, so when we did that case, we found that because of our transeptal puncture, we were coming across the anterior leaflet a little bit, and I had a little trouble finding an orthogonal position relative to the anterior leaflet. But when we did rapid pacing, the anterior leaflet was frozen, and that freezing of the anterior leaflet allowed us to easily go across orthogonally. So, and then it just became a serial dilatation, and that was that. The one question I have for you, actually, Steve, relevant to this, if I could interrupt you, Chairman. Why doesn't the aortic root become injured when we do this? I mean, help us understand that anatomically.
I mean, you'd have to take a weird angle to hurt the aortic root and something like that.
But the risk of tearing anteriorly, you don't think that, I mean, is this overblown? Help us understand that.
So, there's the aortomitral curtain right there. You'd have to split pretty far up to hit the annulus. It can be done. Obviously, we can hit the aortic annulus with a replacement, but you have to go perpendicularly about 1 centimeter up there. So you'd have to split pretty hard. And that's why I think they go mid, left and right, up and down. You don't want to get too high up to the annulus. Then I think you could do it. So, Trekker, somebody comment on the difference between this or advantage of this versus a lampoon, and do we have enough knowledge, for splitting it, which seems to have the same advantage of getting the leaflet off the cells. Why is this so much better? Or is it? Do we know?
Oh, I think it's, in terms of positioning, it's much more reliable. I mean, if you know, when you compare this to Lampoon, you're pulling inferior. You're hoping things stay anterior as you pull. It's different. You know, this one, you literally don't have to snare. It's just a matter of making sure your first traversal is in the correct place. And if it's not, it's not. Lampoon, you know, depending on where the tissue is, if the valve, Nadira and I can talk about a case we had a terribly calcified anterior leaflet, that what we thought was Lampoon was not the part we needed, because it'll go where it tends to be softer. Remember that case, Nadira?
Yeah, and I think it's really crucial in the pre-procedural planning to analyze this with your CT folks. If Rusha or Omar is here from San Francisco, they do a lot with Jafar. I believe in my webinar, Jafar and Jamie actually prefer the Lampoon. You know, if you recall that, for certain reasons, you know, this seems pretty much easy. I remember after the case, me and Paul were like, oh, this is simpler than the Lampoon, because Lampoon was technically challenging with so many things. But I think it really depends on the case-by-case basis, and really where the location of the calcium is.
I think we should think of those techniques as complementary, not sort of competitive or exclusive. There are certain cases where a calcified leaflet here may make it a little bit tricky to control where the balloon inflates, and if you're too close to the annulus, you cause annular injury. So I got a call from Gennaro about a patient who actually had mitral surgery and had an Alfieri stitch in the leaflet, and he needed now a TMVR. And he said, can I do a Batman on this? I was like, I don't know how the balloon is going to behave with an Alfieri stitch at the tip of the leaflet. Why don't you just lacerate it? And he did actually, and the patient did fairly well. So I think they're complementary techniques. The people who came up with the Lampoon are great friends of mine, so it's not a competition. I think there's a patient subset that will benefit from each technique.
Yeah, I mean, I think the broad question is, we need a solution for LVOT, for TMVR. And, you know, there are multiple right now. And unfortunately, none of them is straightforward. I mean, whether you talk about solutions that rely on leaflet, solutions that are targeted toward the, you know, the septum. You know, some devices, it really doesn't matter. It's not an anterior leaflet problem because the device itself is, you know, is covered. So you need septal modification if you want to address LVOT obstruction. I am hoping that technology will take us in a direction where the reliance on what right now probably, I counted last time, over 7 or 8 methodology to manage LVOT. And I'm hoping that we will get to maybe 1 or 2, and maybe the rest can be solved by some advances in the TMVR devices.
I mean, I'll comment. I think the technology is going to have to change. What we have now is not working. And if you look at innovation theory, you know, it's 15 years from the introduction of something before it becomes a thing. TAVR, introduced 15 years later. PCI, 15 years later. Coronary bypass, 15 years later, becomes this thing standard. It's been that 15 years since we've gotten our first TMVRs, and we're still sputtering about. Somebody's going to have to think of a different way other than putting a Diet Coke can into the mitral valve. There you go. That is a small TMVR, Paul.
So for us, I think you bring up a very good point. I think if we stick to the basic concept, I mean, there are 2 basic techniques here: either cautery laceration or balloon-mediated translocation. And you can call it, you know, the Detroit or the Cleve or whatever it is. And if you stick to the basic concept, there are 2 main ones, and you need to be comfortable with one, hopefully the both. But one is going to be your workhorse. And you know, if your patient doesn't benefit from that one, then you sort of go to the alternative. But again, I'm hoping that the technology is going to evolve to where we don't need to do all of the stuff. And, you know, we'll see.
All right, thanks very much. We'll move on now. Markus is going to tell us about advanced imaging saved this mitral case.
All right. Okay, no fancy acronyms for this one. And this is going to be a little less complicated than what you have seen so far, okay? But hopefully it's a good learning value. So it's pretty simple. This is a 63-year-old woman with progressive dyspnea for a couple months initially, and then just for pertinent history, she has had a mitral valve repair 8 years prior for mitral valve prolapse with severe MR. She had a 34 millimeter CG future, semi-rigid ring, and P2 knee accords. And I'm going to show you the outside facility TE she had done 4 months prior to additional workup, which we'll go over, and she had normal labs. So I didn't do this TE, not trying to make any excuses, but this is all you get. Okay, this is a TE, and you can see it's got a high gradient. This is everything. This is basically the whole study. I looked at the start and end, and it was like a 2-minute long TE. So this was, and maybe you can see something mobile on the posterior aspect of the ring on the upper left image. So very little MR, high gradient, and that's where we're at. So then she was placed on anticoagulant therapy with no more events as far as neurologic, and then she had progressive dyspnea though, and it was attributed to her elevated mitral gradients. So then, what should we do next? Remember, advanced imaging saved the day as a clue.
Well, we need advanced imaging.
Okay, good.
Right, we need more imaging.
Excellent choice.
Did I guess
Okay.
right?
Right, and you can see the ... means what we used. Okay, so cardiac cath, nothing remarkable. I mean, a little, the wedge pressure was 18, normal cardiac index, but I want you to pay attention to the CT. And this theme has been brought up a few times today about, you'll see what the theme is. But anyway, we're thinking about valve and ring, right? She's got dyspnea, high gradients, bioprosthetic mitral stenosis. Neo-LVOT, 282 millimeters squared. Plenty of room. Anyone want to just jump ahead to a valve and ring? Or am I leading you astray?
Well, is that what the advanced imaging said to do?
Okay, so this is advanced imaging, right? But you want to see a little more?
It looks
You wanna
pretty,
see
it looks
more.
pretty fancy. I don't know.
Okay, see more. Here we go. So let's see more. Okay. Now I want everyone to pay attention to this cine loop. Take a look. And anyone want to volunteer if they see anything that looks a little unusual here? Remember, this is a ring repair. Maybe look at the lower left image as it comes in and out of the plane. All right, I'll just jump ahead to the next one. How many of you have seen this? I hear surgeons tell me they always see a little bit of something, but I don't think people are used to seeing this much. But I will tell you, I've seen this multiple times now. So look at what you're seeing here. This is severe pannus inside the ring.
Remind me what kind of ring it was?
It was a CG future, right?
So I was going to say on the very first non-advanced image that you showed us,
It was very non-advanced.
Yeah, it was very non-advanced. If you think about it, it was a 34. So if you take trigone to trigone, and that's how we labeled these as a 34, the AP diameter should probably be about a 26 or 28. And that looked like the actual functional AP diameter had pulled up. And so we see pannus overgrowth, and this person is 8 or 10 years out from the repair, and this is probably the mechanism. And I mean, everybody heals these rings in with scar, but some people get this almost like a keloid overgrowth of the ring itself. And the one tip off that nothing else was going on is the repair itself looks fine. There's no MR and something like that. And we see patients late, usually late. I've done my own patients 25 years out with this kind of finding.
So the thing I want people to notice in this is that a lot of times people are hung up on doing measurements. And I've seen this a number of times where people just do the valve and valve app or the valve and ring app. And I'll show you some more PANI cases or whatever in a little bit here. But what I want you can't ignore this stuff because it can really affect the success of your outcome or what you do. And so recognize this pattern in a ring. That's a good term for it, keloid. This is a huge amount of tissue ingrowth.
When you take it off, that's actually what it looks like when you send it to pathology. It's keloid.
Yeah. All right, so that's what we have there, and I'm just showing you that area is actually, if you look at it, it's pretty small inside the ring, it went down to, you can see it's 1.4 centimeters squared, which is like in the moderate to severe mitral stenosis range. And then at the leaflet tips, you see it at the bottom, it's also about 1.4 centimeters squared. Okay, and then here so anyway, here's the clinical challenge, right? Should we do it, regardless of this, should we do a mitral valve and ring? Should we do a surgical mitral valve redo replacement? Should we do medical therapy? Is this all thrombus and you think it'll melt away?
She was 63 and otherwise healthy, correct,
Yep.
Marcus?
Yeah, I know
Yeah.
where you're going to go with this.
Well, yeah. I mean, she needs a mitral valve replacement. You're going to put this little tiny
So
valve and
this
ring,
is no
stick it
challenge
under
for
the
you.
LVOT.
Would any other panel member want to do something different? It's no challenge for him.
So I think redo surgery here is the right choice. I do not know how to get around such a significant amount of pannus
Okay.
and how you can actually deploy a reasonably sized valve within that.
So I completely agree with both of you. The point is that I've totally seen this ignored. And then if you ignore it, then you just do a valve and ring. Okay, so please don't ignore this. So this is what was done. This is just showing you, if again, you can look at it on the cine and also in the cross-section again, but to your point, this is exactly what was done. And that's what it looked like. It's a perfect match for the image. There was like a little thrombus on that posterior valve. We actually could see that on the advanced imaging CT scan, and that was that. So
That's a great case. It's a great example, and I'll make a comment on this. Early in my career, I would take some of these patients back, and you take the ring down and very carefully peel all this keloid junk out of there, and the valve repair is totally fine. It is totally fine because it's all in the plane of the annulus. And I re-repaired a number of them, and then 6 months later, when I was taking them back for the third time redo, no one was pleased by that. No one was pleased
it's
by that.
replacement if they're
Replace them.
keloid formers, is your point.
They have something wrong with them. They react to it.
Yeah, do you think it's an annulitis or something like that?
We have sent the tissue off, and I don't
It's
know
not
the answer,
inflamed?
but I
Okay.
do know the answer is don't try to re-repair them. That's
All right.
personal hubris on my part.
Okay, so then let's go back in time to when we kind of noticed this prospectively, but we weren't as smart as you guys, and we said, we'll just go ahead. And one of the surgeons actually said, oh, that stuff will squish away. It'll squish away. And so this is someone that had annuloplasty ring, this is a different patient, pannus, keloid, whatever you want to call it. And I want to show you what happened. Look at how constrained, that stuff does not all just push away. Look at how constrained that is and how hourglassed that mitral valve and ring is.
Another comment on this is this really only happens in complete rings. It's not seen in partial rings. In the vast majority of cases, we use partial rings. I've only ever seen this, and both of these cases were complete rings. That's why I asked what kind of ring it is.
Yeah.
I think
Almost
this
always
is,
just seen in complete rings. Do
I
not
think
know
this is
why.
amazing because I think I had a case just a few months ago of a valve and ring where I had an image like in the top right.
Yeah.
And I know the valve or the ring is fully expanded, but I still had a lot of deformation, and I couldn't figure it out.
It's probably the answer.
Despite
You should go back and
post-dilating
look at
so
the CAT
much.
scan.
Well, I didn't have you as my advanced imager, so I don't know if I.
But you got
missed
Joao.
this. Yeah.
Ouch. Ouch.
Joao is
I didn't call Joao just now. I'm just saying.
maybe
that
Joao wasn't the reader that day. Okay. So
wasn't reading
anyway, but this I do want you to notice this pattern. It does not just all squish away, and this patient was very old. No one wanted to. They were like 86 years old. No one wanted to do it. But this is what happened to this patient. Look at their 1 month follow-up. I mean, they got a mean gradient of 15 at a heart rate in the 80s, and you can see all that turbulent diastolic aliasing. It's not a good thing. So he had problems with persistent mitral stenosis.
I think this is a situation you get a patient like this, it's ride or die with surgery. That's the way it is.
Good point. And then this, I'm switching a little bit. This does not only happen. This is very important because it can happen with bioprosthetic replacements. This happens to be on the right side. This is one that was from a couple months ago, so it was recent. But look at all this inside this person's this BioCore tricuspid valve replacement with severe TR. And this person was very resistant to have redo surgery, and I'm not going to get into why, but we ended up downsizing one, and we knew it would have a high likelihood of failure, but and she was explained all that, and she wanted a tide me over thing for hopefully a couple years. But what we decided to do, it would have been a 29S3. And what we decided to do was to not do that and do a 26. And she actually did well, and it was minimally constrained. So some of that did push aside. I think there is something to be said maybe for the Hounsfield units that are, if they're on the lower end of the spectrum, maybe this is more deformable. That remains to be determined. I do have one follow-up question to you. And again, please recognize this pattern. It's not just a valve-in-valve app. There's things that can change how you approach things because of it. And also if you had a halt or something, and these are...
I was going to ask, was this patient on Coumadin for 90 days after their implant?
They're going to stay on.
No. The first time from their first surgery. We don't know.
That I don't know. It was a while back, and I actually don't know. But anyway, these are the teaching points. But I want to follow up with one question to you. It's more than just measurements doing this on, and cardiac CT has so much anatomic information, especially if you get a good quality scan. Please leverage it and use all the information you have. You can really find important findings that can change your course. And if you have PANIS, especially halt, I've had requests for, can you please do a valve-in-valve mitral analysis, and then I could have just done it and done the measurements, and I found out they had a halt and all they needed was warfarin. And actually I've seen the gradient and everything go away completely. So this is a diagnostic scan. It's not just a measurement scan. And then, so this can really affect the approach. I wanted to get back to though what you were asking or saying. A lot of surgeons are not doing complete rings. It makes it easier for us if we want to do a valve in ring, but can you tell us like the why other than this is not very common, but Paul, like it happens. And in fact, it even happened on Monday. I saw another patient with this, but what is the reason you don't want to do a complete ring?
It's not this. This is a relatively rare finding.
This is rare.
I mean, most of the patients who come to my practice are relatively young, relatively elective cases, and so I don't want to constrain the annulus anyway, so I put a partial ring on there, and most people have gone to that. We do know that, if it fails, then we're trying to put a valve in ring or something like that, and that's why none of mine fail.
Perfect. We'll send everyone to you.
So I don't think anyone would decry or have a riot if you put all complete rings, but this is only seen in the complete ring.
Do you think it impacts the area adversely? Like you're more prone to stenosis or just more unfavorable gradients by having it be complete, essentially, right?
Yeah. And you have to be very careful, obviously, about putting stitches across the anterior annulus because you can actually end up shower curtailing or quartering the anterior annulus, and that pulls it down and makes it look weird. So most people for straight up degenerative disease will use a partial ring now.
All right, good. Correct. I even saw it on your case that you showed, but I noticed it on, there was some of this, I think, on the one that you showed. Yeah, it is. You need to just look at the tissue that's there. They always say like, porcine leaflets, 1 millimeter, pericardial leaflets, 0.5 millimeter. But when you start seeing stuff that's way more than that, there's stuff growing in there, whether it's thrombus or pannus or keloid, like he's describing. It can happen on this. It can happen on a ring. No one thought it happened on rings. You knew that, but cardiologists don't know that.
So, I mean, Mark, I think it does happen. It's more rare on a bioprosthetic replacement because you think the scar has to grow up and over and higher and come back down into the orifice or come underneath, whereas an annulus, if it just reacts to the annulus, it starts getting the orifice. So it's rarer to see this chunk. The only time we really see this is when the patient hasn't been adequately anticoagulated for 90 days, and then they have halt, and then they're off and running. And I think because of all the TAVR data, surgeons are more aware of that concept. There are surgeons out there who do not anticoagulate bioprosthesis except maybe with an antiplatelet. And you know, the ACC AHA says 90 days of Coumadin, 90 days of Coumadin, nothing
But
else.
Steve, are you implying we should do that for rings too?
So I do put my rings on Coumadin for that very reason.
I don't
know if
this
that's
I
the
don't
right
think
answer.
most of us are. So
For this reason?
for this or for just routine practice?
Just routine practice. But certainly for bioprostheses, everybody
yes.
should be on Coumadin for 90 days.
So the guidelines for the ACC are for bioprosthetic valves,
Absolutely.
not for rings.
Absolutely.
Right. So
Right. There is no guideline for rings right now.
Correct.
I guarantee
That's what
you.
you're,
Yeah,
but that's what you're doing. You're doing anticoagulation
That's what I
for
do.
rings.
interesting.
So one thing I would say, and rings are, are a blessing and a curse at the same time. I mean, even if you look at the registries and multiple has been published, the outcomes in valve and ring is not as good as it is for valve and valve mitral. And I would say I hope all rings are put in for primary disease being MR. But whenever the recurrence of mitral disease is not MR, is always worrisome of us missing something. And this is, I would say, if the recurrence of this disease was MR, I probably would have missed it. But like you nicely showed that there was no MR, and the gradient was just 12. So it's very easy to say, well, it was a ring and it was mismatched. But if you go back to the implants, it's hardly ever that anybody would leave the operating table with an MR of 12. So I think that what we have done in our practice is the moment that the ring failed with MS, we always worry: are we missing something? Is there a thrombus or endocarditis or something that we missed at some point or an autoimmune disease that could have explained what happened? The case that you presented is purely MS. There is not even a drop of MR. And Steve, I'm not sure if I got this wrong, but somebody told me once that complete rings are for functional only, because you want to bring the annulus, and the DMR primary is semi, just to prevent LVOT obstruction. I mean, that's
So the DMR, the vast majority of practice now say 85% are partial rings. But for FMR, if we're going to repair FMR, and that remains a problem, then a small complete ring. Right. Anyways, Markus, great case. Thank you. That was very advanced.
Partially advanced.
All right, we're going to skip over. Dr. Basra is going to tell us about transcatheter mitral valve replacement challenge.
we're doing very well on time, Steve, despite missing the speaker.
I
We're
know.
behind.
Yeah, we've managed to do that. We've managed to catch up with ourselves.
Good afternoon, everybody. Thank you for the panel for this invitation. I'm going to show a case. I think, Paul, you've been involved in this to some extent, I guess. This is one of our 10-9 cases, and I think one of the first few ones that was done in a patient on dialysis. So compassionate approval, thanks to Paul, and thank you for the invite. I thought this would be a good place to share this. These are my disclosures, not really relevant to this talk. So getting on with the case, this is a 63-year-old, very functional guy. He's had a previous history of a kidney transplant back in 2008. I saw him in 2023, and he had already had a failure of his graft in 2015. So 7 years on dialysis, 2015 to 2022, and 23, he was thinking of getting retransplanted. So that's when he saw us. Unfortunately, he's quite symptomatic, NYHA class 3 at that time. And I'm interventional in heart failure, so we see all of these patients for heart failure for transplant listing. Turns out he clearly was not a great candidate. He had severe MAC, plus had severe MR, plus moderate to severe MS, as we see in a lot of these patients, and also dialysis. This was the time before we had any FDA approval for any TMVR devices that could be done commercially, and obviously all these patients are excluded from trials, so then we were in a conundrum as to what to do with this guy. His imaging, I'll go over all the things, but essentially his EF was preserved, thank God. Mitral valve was very calcified. Severe stenosis, his gradient on the transthoracic was 13 millimeters at a heart rate of 60. He was very adequately beta blocked. MR was severe. Thank God the heart cath didn't show anything significant from an obstructive standpoint. But look at his hemodynamics. I put him in the hospital. This is kind of our standard practice. Anytime any of these patients come in for workup, we dialyze them extensively for days until we think there's not a drop of volume overload left. I was mistaken here. He still had an RA pressure of 13 after like 6 sessions of dialysis back to back. Yet with that, when we tried to dry him up, his PA pressure systolic was still 89. His mean PA was still 52, and his wedge was 26. This is obviously from a combination of MS and MR. And I'm sure when he was not adequately dialyzed or doing the regular 3 times a week physiological dialysis that we think we always do, I'm sure his PA pressures were probably in the hundreds, and his wedge was probably in the 40s. And he has a fistula, and even in the setting of a fistula, his cardiac index is 2.5. So you know that this guy probably has a very deranged hemodynamic state. Most surgeons would not want to operate on him with that kind of PA pressure, and especially in the setting of MAC. So, and he's also 63, and now he wants his new transplant. So that's where we came in, and I did a transeptal. LA 12-week gradient was about 5, but I think that was grossly underestimated given his EDP was quite high. Valve area on mitral valve, I'll show you the images, was calculated as 1.5, and planimetry was even worse at 1.3. As I mentioned, the cardiac index was 2.5. So looking over his imaging again, you can see his EF is preserved. He's got severely stenotic valve. Gradient on TE was 8. Valve leaflets are both calcified anteriorly and posteriorly. Subvalvular apparatus, thankfully, is not too bad. Central jet of MR, but look on 3D, the valve is stenotic quite a bit, and there's that central MR jet. Gradients were 8. LVOT, thankfully, didn't look too bad, at least here. And then on planimetry, as you can see over here, valve area is 1.3, calculated was 1.5. We did a CT to see if he would be a candidate for anything, and so you can see the calcification pattern. Obviously, we've seen much worse calcium. I'm sure there'll be cases here with that, but this is what we had to deal with. There was some involvement of the calcium extending to the atrial wall, also into the posterior mitral valve as well. Our surgeon said, can you do something? We think this is high risk. And I'll open up for discussion if anybody else thinks we could do something different from a TMVR here.
Paul, you want to put a Tendyne in this guy?
Sure. So it's interesting. So actually, the second patient ever treated in the United States with Tendyne wasn't my patient. We did the first and second, and the second patient actually lived 10 years, dying just two months ago. And 9 of those 10 years, he was on dialysis. So honestly, the dialysis doesn't scare me, even though I think a lot of people would be a little scared of dialysis with the tissue valve. And I think it's just, you just do the best you can, and that's probably his best solution.
Yeah, I thought Paul would say that, and that's why, since he was on the MAC committee at that point, we brought it up, and he was graciously saying the same thing, that he had a good experience in his patient, and that even though this would be out of the trial, this would be compassionate approval, we'd need the backing of everybody to get this case through. But the company was very generous, the committee was generous, and then obviously the patient wanted to move ahead. So
Remind me how old the patient was?
He's 63.
Yeah. So, obviously, renal failure, I don't know how you get it, but I don't want it. And dialysis is really terrible. The amount of calcium burden that he has actually is not that high. It didn't seem like the worst case of MAC we've ever seen. We treat all surgical patients, obviously, we use a sonopet or some type of, emulsification ultrasound device, and our theory is just to burn a round hole into it and then sew as much as we can to make it hold still. We're not really scared of dialysis. These patients are higher risk, but we would consider either surgery for this patient or we would do a Tendyne as well. I think that's our pros. Russ?
I mean, I think this is a very good call, because dialysis patients for both mitral and tricuspid, they're excluded from all the trial, which is a big problem, because especially with, for example, tricuspid, they have cardiorenal. This is probably how they end up on dialysis. So I think I don't know if we have anybody from in the room who from industry, but we have to figure out either a registry or some sort of way that we can treat those patients, because I agree exactly with what Steve was saying. We fear them, but and dialysis is a horrible disease, but many of them will, and we've treated commercially patients with on dialysis, and as Paul was saying about that patient, they lived.
The
Firas, to
only
your point.
trial I know is High Life. I believe High Life is the only one that allows dialysis, but everyone else, it's an exclusion, and it's a problem.
And it's so difficult to try to wangle them in. I'm glad you did and something like that. We probably would have taken this patient to the OR.
So for us, one of the issues is who's going to pay for the device. If it's not commercially available yet and it's in trials, you don't have access to the device except through the protocol. And if it's an exclusion criteria, there's really little wiggle room from a regulatory perspective to be able to put in a device that's not commercially or FDA approved yet.
You
Set
do
to
enough
find-
compassionate cases, your finance officer will not be compassionate with you.
Yeah, I think this was probably it's our 6-10-9 case. The first 5 had gone well, so thankfully they were willing to support this case. I think from a Max standpoint, I agree with you. The compassionate officer was not very compassionate with us, but I think given the fact that he was 63, already was being worked up for transplant, I think everybody said this would be the right candidate. If they would let us do one, this would be the one they would let us do. In terms of your discussions, in terms of surgical candidacy, I think we pushed back and said, well, let's go for surgery if that's an option. And I think our surgeons didn't feel comfortable moving ahead with this. The other options would be we would do a hybrid approach, like Mitral procedure, which we do in some of the other hospitals. And we've done a few Mitrals. I'll be honest with you. I think some of them do well, but I don't think the results are as great as I would like to be. So I didn't push for it too much either.
We've done citrals. I think the bloom is off that rose a little bit, and we would just fire up the ultrasound. And he didn't have that much MAC in there, so I think we probably in our institution would have taken this patient to the OR.
Which disease is better, dialysis or MAC? Is worse? Better?
Yes,
Which one?
yes. And then obviously they're interrelated. It's interesting. We looked at a series of probably about 500 post-dialysis patients, whether we should put a mechanical valve in that patient, depending on what age, and a biologic valve. And the answer is they do so terribly, it doesn't matter. It just doesn't matter. They don't live long enough to get the extra effect of a mechanical valve being in there. They have all these complications. And yes, they do calcify their biologic valve, but it doesn't matter. They die from their other disease.
And it's a spectrum, right? Dialysis. Not every dialysis patient is as compliant. So I spoke with his nephrologist several times, made sure he shows up to his dialysis sessions, make sure he's the right candidate. So I think we pushed for 10-9. We got approval. This is kind of what happened next. So the challenge, as I mentioned, obviously MAC, which thankfully wasn't extensive, but eventually does play into it. ESRD, pulmonary hypertension. To me, I think his hemodynamics were the clincher in terms of getting him out of the surgery with that kind of peer pressure and his kind of deranged hemodynamics. I think that's kind of what pushed
really,
us over.
surgeons are not afraid. I mean, this guy has crazy pulmonary hypertension, but pulmonary hypertension to us just sort of means if you can preserve the RV and that the RV is still functioning. What we hate is when cardiologists tell me, like, Steve, this guy had pulmonary hypertension, but now it's better. That means it's deader. That means the RV is dying and the number, it just can't push forward anymore. So
Exactly.
that doesn't really scare the heck out of us. This whole case I would refer to one of my partners, though, of course.
So we pushed ahead with the evaluation for a compassionate approval at that point. We got the CT and sent it for analysis, and it came back anatomically suitable for 29 millimeter 10-9 low profile valve. The process, as you said, if you're part of the protocol, then you have to first petition the FDA. Obviously, the patient has to be on board. You have to have a non-involved physician saying, yes, this is the only approved treatment that we think we should go for. Then the university IRB has to approve it. The hospital IRB has to approve it. And then it's a lot of paperwork, but we pushed through it. Obviously, 10-9, I think, I won't go into it in too many details. We've all seen it. It's approved now. Hopefully, we'll get our hands on commercial very soon. This is a CT analysis. As you can see over here, the perimeter was about 92. Calcium anteriorly and posteriorly, but not as extensive. His calcium MAC volume was about 1,142. I think the trial threshold was 425, but I think that you've treated up to 38,000, so clearly nothing compared to what you guys have done before. Neo-LVOT, I would say, was acceptable but borderline, right? 252 on the smallest and end systole. But he also had a fairly longish anterior mitral leaflet, which was about 16.3 millimeters. So the combination of those two did put us on alert. Not bad enough for us to say, no, we won't do this, and not bad enough for us to consider modification strategies, but we did push ahead. Moving on, this is our surgeon poking the apex, just a standard technique to find the best spot to be coaxial. Then he got an 18 French needle crossed, and then we put a wire across the mitral valve. Did the standard Fogarty ballooning to make sure that we had nothing on the path and that we were clear of the PAP muscles. And on the fluoro, here's the sheath going in. We transitioned to a Safari, and then got the transapical access with the Abbott sheath in there. And then we did valvuloplasty in this. As you can see over here, the balloon's going up. And then on floor, the same thing. Mostly to be able to make sure the inner frame expands well. I think there was one little bit of chunk of calcium on the posterior leaflet that the thought was could be a problem with the inner frame expanding. So that's why we did valvuloplasty. And as you see, there was significant increase in MR afterwards. Did not need a balloon pump, but we were ready at that point. This is on MPR, positioning the valve. You can see the crown coming out, pointing anteriorly, and the valve is flowering, and then we are pulling it down and seating it against the anterior leaflet and posterior leaflet. And eventually, this is the valve after we're doing the apical tensioning maneuver and getting it seated. No LVOT obstruction. Gradient, I think, on cath was about 8 millimeters.
Yeah, he still has mitral stenosis.
So it's
I mean, he
gradient
still
actually-
has a corona, an inflow corona.
But part of it is also that he has a high flow state from
Sure.
fistula as well. So I think that's a lot of it is physiological. So he's about, I would say, 2022 October is when we did this. So he's about close to 3 years out on the kidney transplant list, waiting for her kidney. He's had one hospitalization for AFib RVR since then. This is his echo 1 year out. Looks great. I didn't see any MR, just a trickle. No MS physiology there. Gradient across the LV was still pretty good. So we got through the case, but what really bothered me before we did this was his hemodynamics, right? And that was another reason why he was going to be excluded from the trial. I repeated his right heart cath more out of academic curiosity than anything else, but look at his numbers. Artery pressure 2, his wedge came down from 26 to 26 to 6. Mean PA came down from 52 to 19, and PA systolic from 89 to 26. This is on regular 3 times a week dialysis. This time I didn't put him in the hospital for a week and commit him. And he's class 1 NYHA, playing soccer with his grandkids 3 times a week, and just hoping he gets his kidney as quickly as possible. So the point of the case, from my perspective, I think, obviously this therapy is going to be available pretty soon. They're going to have a limited release. Like anything else that we've seen before, once these things get approved and they get available, there's always this risk creep that comes. So I'm sure there's a lot of patients with dialysis that we all have that, and other kind of hemodynamic issues that would be not candidates in trials. But we have to be very careful and try to pick the best patient possible. Not every dialysis patient is the same. Some are really probably better for palliation at that point, and some are like him, who do everything by the book and maybe deserve to get a shot at some kind of therapies like this. It's a team effort. You need to get your heart failure doctors, cardiologists, surgeons, anesthesiologists, everybody on board, and then obviously the research pathway as well. And then don't be afraid if you see out of proportion pulmonary hypertension. We always think that, okay, this guy has out of proportion pulmonary hypertension. There's a 26 millimeter transpulmonary gradient. Probably even if you get the mitral valve fixed, this may not improve perfectly. This guy's a great example. His hemodynamics absolutely normalized. I've cleared him for transplant, and I'm hoping he's going to get it any day. So that can happen in patients with chronic MR.
So I think a comment on that, and we see this in dialysis patients, and it's not really out of proportion pulmonary hypertension. It's because they can't dialyze them with mitral stenosis. So they do have pulmonary hypertension, but then they're absolutely flooded. And so you cannot get the volume off them because, you know, if he really has pulmonary hypertension to 90, it's not going to come down to 26. I'm sure there is some remodeling, but most of it is now that they can way more effectively dialyze them and dry them out.
That's a huge part of it, absolutely. Thank you, that's all I had.
Great case. Okay, and Paul's going to bring the last one home, a challenging valve in ring.
All right, thank you so much. Disclosures? Okay, so this is a 77-year-old woman who is actually quite complicated. She had a TAVR that was placed at an outside hospital. And the TAVR initially was a really good result, but then in follow-up, what they found was that the evolute, which had been placed well, had started to slip into the LV. She had a previous surgical band. Don't ask me what type or what size. So there was some band there.
What type or
And
what size was it, Paul?
I say, look at that. Just wish I could throw something at you right now. But she had evidence of MS, okay? So here's the echo. Beautiful images by Nadira. You could see here, not a normal looking mitral valve, no MR, and you can see the 3D on the right-hand side there. and here's the CT. Okay, so we were asked to look at her at our hospital for a valve and a partial, is it a partial band or a partial ring or half a ring? I don't know. What do you call these, Steve? Some partial something.
Yeah, partial ring.
Yeah, and whether or not we could get around the evolute. If you just went straight in, the Neo-LVOT is a little small, but that's what we size it up for. So here's the challenge. Severe MS, prior surgical ban, a low TAVR implant, valve and ring. If we're going to do this, how do we manage the Neo-LVOT? What do we do about anchoring the balloon expandable valve? So if we're going to put a SAPE in, is it going to sit and anchor with the evolute there with a partial annuloplasty band? I mean, Firas already said that valve and rings don't always turn out well. I think valve and partial rings are even worse. What's going to happen to the evolute if we put a SAPE in inside? So, Ricciardi, I'm going to call on you because you're the most senior CVI faculty member here. Yep, so that was a question. So if you couldn't hear, so the question from, or the comment from Mark was, the evolute being low, does that help overcome the fact that the mitral band is partial and thus serve as kind of like a pseudo trigones? I don't know. Firas, what do you think?
Yeah, I'm not sure that it'll make a difference. I mean, I think surgical valve do, balloon expanding valve do. I'm not sure about self-expanding valve. I'll be nervous relying on anchoring on it. Yeah.
Yeah, because the inflow segment evolute, it's obviously going to be quite small. Okay. This Neo-LVOT, Markus, yes.
Paul,
do you have some advanced imaging to talk
can you
about?
go back to the advanced imaging
Oh
CT?
my God! I knew there was going to be something I missed here.
Okay, look at it on the right. You got it like a heart-shaped ring inside your ring.
Is that panis?
I mean, it's pretty thick. And I'll tell you something, Nadira, when I see a TEE that from above, the hole looks so small from the above left atrial perspective, I've learned that I've become more and more worried that it is at the annular level. I mean, look at how small the annular hole is on all these images.
Yeah, on the far left TE, I mean, that may be cut funny, but look at the right panel and the far left panel. There's
I
like no hole there.
I wouldn't tell Nadira her images are cut funny.
Then obviously, I did not know she did then.
She'll
They're
take
perfectly cut.
Yeah,
They're perfectly cut.
No, but it's not only that. Look at where the aliasing and the piezo head starts on that. It's happening at that level. The stenosis is happening right there at the ring level.
So
yeah, and with the color on it, like the inflow is just a peewee through the mitral valve.
So here's the question: does this rebuke your theory that it doesn't happen in incomplete rings?
It's just a theory.
You don't know what you don't see. That's the rule of structural heart, and now
It's
you
a
see
guideline.
it. Now you see it. But I do think you should look at that image because, and also the other thing that happens is if you put something in there, seriously, the perivalvular leak risk and stuff goes down because that stuff will have stuff around it to seal it.
So what are we gonna do here? I mean, she really doesn't want surgery. She's already had surgery. She's elderly. To go to surgery, you might have to dig that evolute out. I don't know. To get to the mitral. She's not a great surgical candidate. She really wants a transcatheter options. What do we do? I saw Sachin out there. Where's Sachin? Sachin, what would you do in Houston?
Are you worried about cauterizing the evolute? Fire right through into it.
Yeah, so if you're going to do lampoon, go. So double balloons through the LVOT. So kissing balloons, aortic mitral kissing balloons. DK, Firas, what about double?
I mean, one thing I would say though that this is the same as the case where we're talking about this the keloid whatever growth in the ring, but this is an incomplete ring, so I think that this ring will expand. So in a way that you're not going to be able to displace.
So that means we can ignore Markus's comment about this panis because it's just going to expand.
I think it actually has. I mean, functionally, it's almost become like a complete ring because the evolute has become the part of the aorta. You see it on the image. It's basically so. Maybe this gives him points back that he's right. It is indirectly a complete ring. So, but just look at that image, and I don't know if there's some reaction that happens in these patients. There's some inflammatory reaction.
Dhaval, what do you think?
Yeah, I think, I mean, I agree with all the comments that have been made so far. I think kissing balloons seems to be.
Kissing balloons. I wish I had thought of kissing balloons because I actually think that would have been pretty fun. Yeah. So, all right.
So Paul, just a quick comment. So on an optimistic approach, you would think that a slipping into the LVOT TAVR, a deep implanted TAVR, would probably minimize your chances of LVOT obstruction because no matter how much you push the anterior leaflet, you're never going to come in front of the TAVR. The TAVR is going to be sort of a barrier, if you will, if it's deep enough. Now, I can't tell on these images if it's deep enough to prevent that.
So the way we modeled it, and I don't have the CT overlay for you, is that we modeled it and tried to see if that would be the case, but we were really worried that that LVOT and the anterior leaflet would be obstructive.
I see.
Yeah.
The balloon.
So we felt we needed to do something to the LVOT. So what would you do?
I mean, if the concern was for LVOT obstruction, I would consider a modification technique. And
your favorite technique is?
Whatever works best for the patient.
Nick, what would you do? So you like the Batman? And what was it? What was the second part? Modify the septum. So I thought about an ablation, but if I remember correctly, she didn't have a good artery. So, and plus we'd have to go through the evolute. You know, it's a little bit of a challenge sometimes. All right, so yes? Using a what? Alta valve. That's a good thought. We didn't explore that. Would have been a compassionate use approval if we did. No, but there's mitral stenosis. That's right. That's right. So that's one thing. Yeah. Yes, Sachin. First or after? I know you're gonna say same time. That would so yeah, you could put DK crush, DK TAVR crush. Okay.
It's gonna have to be. The problem is if you put the mitral first and then you put the you might crush the mitral.
Yes.
Or atrialize the.
Well, that's the thing about DK crushes, right? You never have a full, beautiful carino. Something has to be crushed. All right. So this is what we did. We were inspired by Tarek. We were inspired by you.
Thank you.
So we did a Batman. So you can see on the far left-hand side, we did an LV gram just to make sure. I always like to do this for Max because I want to make sure the MAC is the annulus. You know, sometimes you get fooled where you're going to implant and put your deployment marker. You can see in the top middle there, that's Nadira guiding our steerable transeptal, pointed directly at the anterior leaflet. And then under her guidance in the bottom middle, we actually did this with rapid pacing, and we like that because we did that with Tarek the first time, and the anterior leaflet becomes very stable, and in rapid pacing, the anterior leaflet sits in systole, so it sits as high as possible to make it flat for the crossing. You can see the top right, that's the actual crossing, and the fluoro on the right-hand side is also the wire just going across. So with the wire across, you can see on the left-hand side, there's a catheter that's confirmed to be through the leaflet that Nadira is showing. And then on the middle image, this is an ostado. So then we take a coronary balloon to dilate the anterior leaflet. This is just a 3.0 NC coronary balloon. And then over that, the piggyback or the microcatheter is then tracked into the LV over the wire. And if you watch carefully, you can see it as I'm pushing, the guide is kind of being backed out a little bit. And that's just because the microcatheter is having a little trouble getting through, but then eventually it just falls through into the LV. And then through that microcatheter, we then actually just advanced the multi-purpose, which just fell into the LV. Then through the multi, we put the Safari. And then this is very similar to what Tarek showed you earlier. You can see this is the balloon mitral, the valvoplasty balloon across the mitral. And you see it's a super slow inflation. We take this very gradually. And then we dilate that. You can see that. And then if you look on the right-hand side, we put a balloon pump in prophylactically like we've done in the other case, but there's hardly any MR. Isn't that neat? I mean, Tarek, how'd you come up with that? Yeah, well, I mean, I was really struck with how little MR there was, despite that really large inflation. And then over that, if you watch these are full fluoro saves. On the left-hand side, this is the Sapien. It's a 29, just tracking over the wire, and it just flies across the anterior leaflet. And then in the middle panel is the actual deployment. And on the right-hand side, just because we could for kicks, we do an LV gram just to show where it's at. And it was beautiful. And we closed the atrial septal defect with a cardioform on the way out. And she did really just fantastic. You can just watch the deployment there if you want. And this is the post-op echo. So on the top left, you can see the really nice round valve deployed. The MR is all gone. There might be a little pinwheeling in that bottom image, but honestly, we just weren't going to chase it. We just didn't feel it's worth it.
Did you think you ended up with the Sapien propped against the bottom of the Evolute?
Yeah, I'm going to show you that. Exactly. So on the right-hand side, though, I'll tell you, look at the LVOT. See how crowded that is? I honestly think without the Batman, she would have done very poorly. We would have had obstruction. And that anterior leaflet is it torn to shreds, Tarek? What exactly happens to the anterior leaflet? Tell us.
So in the best case scenario, actually the anterior leaflet will expand around your Sapien, and the Sapien will be deployed within the tissue of the anterior leaflet, which will allow you a little bit of a skirt to minimize PVL. Worst case scenario, you actually do a very powerful, strong lampoon-like laceration just with a balloon. You just tear it.
Tear it. So this is the CT, your question. So if you look on the left-hand side, it turned out really quite beautifully. And then if you look on the right-hand side, the inflow of the Evolute is just partially deformed. And the valve function was preserved. And the Sapien, we didn't need a DK crush. We didn't need any fancy maneuvers. I know Sasha would have wanted to put a Sapien in that inflow, but honestly, the gradients were perfect. And she did great. So learning issues, I think the Batman is a very simple, elegant technique. And we did this in a surgical band with a low TAVR. I think the low TAVR did provide some reassurance about kind of serving as some calcified trigones. I think the anterior leaflet and prior TAVR help with the anchoring. And then also, if you're doing these, I do think rapid pacing helps with the stability of the wire cross. So that's all I have. Thank you.
Good case. I think we're right on time now. We'll adjourn. Everyone can have a cigarette and a cup of coffee, and we'll come back at 4 o'clock.